So what I want to do is kind of go through some objectives here. I'd like to start just with a little bit of a historical perspective of instrumentation in the spine, where we've come as surgeons, and it's truly been an amazing, amazing evolution from a really nothing, relatively short period of time ago with respect to the tools and the equipment that surgeons have had, to now extremely advanced and evolving systems, which allow us to rotate and correct the alignment of the spine in whatever plane and angle that we want. I'm going to go through a little bit of basic biomechanics, and really this is kind of more intended for the neurosurgeons. I think the orthopedic folks are probably way ahead with respect to this because of the biomechanics that they study for joints and so on. So it was certainly enlightening for me, so maybe it'll be enlightening for you folks too. And just briefly mention, and the meat of the talk is really what I call anchor and longitudinal members. In fact, this is a term really to describe our three-point fixation in the spine. Talk a little bit then about mechanisms of failure, and then very briefly tips for success. So we're so familiar now with our spinopelvic angles and parameters, and it's become a part of the staple of understanding what we need to correct when it comes to the spine. But as much as it's been, if you like, a dawning for many of us clinical surgeons, really surgeons have looked at this for many, many years ago. Cobb was doing his parameters for scoliosis from the late 40s. And there was a series of other folks all the way up to Dr. Lenke who've evolved and progressed with a system of classification for scoliosis and ultimately used that for correction as well. So, and no doubt, as you heard yesterday from Dr. Shaffrey, this is still an evolution because it tends to become cumbersome at times, and we do need to keep it practical so we can, as surgeons, we can apply it for clinical benefit. But this concept of sagittal balance, which is so important, particularly in adults, is not new. It was really kind of talked about by Stagnara and in the 70s, and then Duval-Beaupère in the 80s, who recognized the importance of correcting sagittal deformity. The issue was that we did not have the data, the clinical outcomes data, the quality of life data to back up the if you like, anecdotal evidence from correction of sagittal deformity. A key event occurred with Dr. Moe and prior to him King in bringing together this classification system and forming the Scoliosis Research Society, the SRS, which is such an important aspect and a great venue and meeting for deformity surgeons. And to this day, I think it's probably a highly regarded society for discussion of these topics. But the importance here is to recognize that surgeons have been involved in instrumentation right from the very beginning. And this is not something that came from industry and then we decided to kind of modify it. Surgeons were the ones that had their elbows in the grease, if you like, designing fixation systems, sublaminar wires, rods, then screws, and then putting it to practical use. And a lot of the regulatory kind of companies or regulatory agencies have really kind of been a little bit behind with respect to kind of catching up with the technology that's presented. But the legacy of surgeons reaches all the way back to with Harrington and Urist and Lucci and others who designed the first systems to correct these deformities. I'm going to touch very briefly on that. So Harrington introduced, if you like, the first kind of true distraction system that involved typically a single rod with a hook at either end, And what it did was that it was very, very useful by distraction for correcting the coronal deformity. And in doing that, particularly in adolescence, he was able to correct a lot of these deformities that otherwise had been really only treated through bracing or nothing. The problem was that it didn't address sagittal deformity, of course. But nonetheless, it was revolutionary at the time. And it's interesting, some of you may still see patients in your clinics today that come with a single rod and a two-hook construct. I know I have. And the first thing I do is stand back and balk at what I'm seeing. But when you think about it, the simplicity of the system and the elegance of it was really astounding. Urist was highly important to all of this because he actually discovered BMP, which has had a very significant impact on our spinal work. It's gone through ups and downs with respect to its applicability, but nonetheless, it's been extremely important in terms of its value for adding on and stabilizing the corrections that we get through extending the fusion. Then Dr. Lucci in the 70s really came up with a major advancement of that single rod system to a bendable rod that he was able to achieve segmental fixation to the spine. And he did this through a series of sublaminar wires that he was able to run under the lamina in this way, add to the correction of segmentally of the scoliosis. But still, the challenge was rotational deformity, and they were still not able to quite address the rotational component of these major deformities. But Lucci rods, I think you will probably see it in your practice at some point, particularly iliac stabilization, and to somebody like me who's never put them in, I would think it's a technical challenge, and the mastery is required to do that, with no connection and literally one rod that's bent from one iliac wing to the other up and down the thoracic spine. And then Cottrell Dubuisset advanced the field significantly by coming up with segmental fixation with hooks and screws that really then allowed us to perform three-dimensional rotation of the spine and really start to derotate these deformities and achieve a significantly better correction in both the sagittal and the coronal planes. And then, of course, this has been advanced through the first, if you like, of the modern systems, the TSRH, which was significantly simpler and stronger compared to prior systems. And now, of course, there's been an explosion of instrumentation with respect to deformity correction. So that's just, if you like, a historical kind of vignette of where we started and where we came from. And really, this was kind of from the mid-20th century to now. Incredible progression. So let's go back to basics a little bit and let's address what it is that we want to kind of see instrumentation do for the spine. So as you know, the spine's purpose is really to protect the neural elements and allow them to fulfill their function. It's to stabilize the torso and the limbs by supporting the body weight, and obviously it provides stability for motion, particularly for mobilizing through walking and so on. So it's a dynamic system. It's living in the sense that there's turnover of these cells. The vertebrae are made up of the cells. 15% of the vertebral weight is made up of cells alone, and then of course you have the mineral components of the calcium and the phosphate, scaffolds, blood supply, ligaments, disc material, and so on. So obviously our purpose as surgeons when we need to stabilize the spine is for a variety of conditions that affect that stability. And the whole purpose of stabilization, as you already know, is that it is meant to provide a scaffold until such time as biological fusion takes place. So it's a race really between failure of the instrumentation of the implants and that of biological fusion being achieved. And selection of the implant is so key or critical to this because the properties of the implants that you'll select as surgeons really depends on the condition that you're treating and the patient and the patient factors that you're treating. So what is the ideal instrumentation? We know the goals of the spine. We know the goals of instrumentation. What do we expect from the implants? Well, obviously, it's got to have adequate strength. It has to be able to do its job. So it can't fail with respect. And typically, failure of implants or instrumentation doesn't occur from a static force or stress that's applied, but it's a cyclical load of force and release through motion, and this is what typically leads to failure. It's got to be easily inserted. At the same time, it can't back out. It can't lead to fracture either of the host bone and be strong enough to prevent fracture of the instrumentation itself. As we talked about, it's got to allow for correction in multiple planes. It has to have a minimal footprint to allow a generous area for bone fusion to occur. And ultimately, in our healthcare system, it's got to be cost effective. So let's go back to the very, very basic mechanism that applies to what I call the anchor and the longitudinal member. So typically in our modern day spine practice, the longitudinal member is the rod and the anchor is the screw. It can be a hook, it can be a sublaminar wire, but typically it's a screw system. So a moment is created whenever there's a lever arm between that longitudinal force of that longitudinal member and the anchor. And there are two typical stresses that are applied. One is the load that increases as we descend down the spinal column due to obviously cumulative load from the skull down and the body weight. And the other is the shear force or the resistive force that resists, if you like, this applied load. And as we know with Newton's laws, whenever there's stability, these two forces have to cancel each other out. And when there's imbalance, one force exceeds the other. And at rest, typically, they balance each other out. But in mobility and in locomotion, it becomes an issue. So a bending moment is when the load is applied to the shear force and there is a tendency for the lever arm or the moment to rotate around an instantaneous axis of rotation or an IAR. And this is known as the axis of rotation for the vertebrae. This construct is known as the cantilever. And it's important, it's really important to kind of understand this, and many of us don't really think about this until we're faced with a clinical situation of where we can apply a force, if you like, a stress, in order to balance or correct a excessive applied force that, like for example, leads to kyphosis in the spine. So following a traumatic fracture and so on, we can apply the principle of the cantilever to straighten out the spine by using our balance force, using instrumentation to achieve that balance, if you like. Is everybody kind of clear on that? I think it's relatively basic, but it's something we need to kind of think about. So a screw, as I said, acts as this load-bearing beam. The load is applied to the head of the screw, typically across this axis of rotation. And the fulcrum, which is B there, is where the moment's created. Now, if the forces are relatively small, at one segment or with the one construct there. But if you apply this through multiple segments from a long rod screw construct, it becomes very significant and very stabilizing as well. So very basic maths, and bear with me here. The magnitude of this bending moment varies in accordance with the force that you apply and the distance from the fulcrum to the tip of the screw or to the tip of the lever arm. Okay, this resisting moments generated by the downward stress applied by the body of the screw behind this fulcrum with respect to the length of the screw, and for a single screw, as I said, the applied moment's quite low because the length of the lever arm's minimal, but you add it up by connecting to implants and it becomes very significant. Okay, this concept is beautiful because then it explains something that we see practically every day, and that is that deformity begets deformity. So if you have, for a relative increase in size of the applied load, you increase the bending moment. The bending moment results in greater distance from the axis of rotation. So a larger moment, applied load, leads to an increased bending moment, which then leads to increased kyphosis. So it's like a pattern that begins. So for a relative incremental increase in the kyphosis, this leads to a bending moment, which then leads to progressive kyphosis. And so this is why I think in some of our elderly patients, what you see is that they've typically had some kind of deformity for many, many years, but they hit that sort of magical period in their 60s or early 70s, and suddenly the deformity seems to become significantly worse. And obviously the resistive forces from the paraspinal muscles is significantly weakened. It's replaced by fatty tissue. They're unable to generate the same, if you like, strengthening forces with respect to correcting their alignment by retroverting their pelvis and so on. And so the deformity begets the deformity, and the pain and the symptoms become significant at that point. So this leads us to another kind of concept, and that is between stress and strain. Again, I think the ortho guys, you can go back to sleep right now. But for the neurosurgeons amongst us, this is a really, really important concept for us to kind of grab. And that is that stress, or this force, it's literally a force that's applied over an area. It's measured in those kind of parameters. And that force can be tensile, it can be compressive. In other words, you can distract, this force can be distracting, it can be compressive, or it can be angular or shear. And shear is the most kind of difficult one, I guess, to grasp because it's complicated. Strain is the response of whatever it is, the bone, the implant, to that stress force. In other words, it's the deformity that occurs as a result of that stress. So it's not just measured in a length, it's a ratio. So it's a ratio of the additional length or deformity to the original baseline position of the implant or the bone. And basically it reflects the resistive ability to these stresses, to the distraction, compression, and angulation. And this is useful because it leads us to this curve known as the stress-strain curve. For some of you who were kind of engineering majors, again, this is kind of obvious. For those of us who spent our kind of misguided college years pursuing funky, uplifting beats and music, this was a moment of enlightenment for me. So basically, this is a very important curve because it describes the relationship between the applied stress and the deformity that's achieved. And what you have is a few zones. A to B is kind of the normal zone. I think it's the zone of slack. Between B and C is known as this elastic zone. So whatever stress is applied to the implant or the bone is able to be proportionally reversed when that stress is lifted. So it's kind of like a rubber band. So you stretch that rubber band to an extent, you let it go, the tension drops off, and it'll resume its normal position again. As you can guess, past a certain point, that's not going to hold anymore, past the pivot point. So between C and D, there's a permanent deformation to the bone of the implant. And after D, then you have like total failure. You've snapped the rubber band. No matter what you do, it's not going to reassume the position again. The reason why this curve is important is that the slope of this curve, of that elastic modulus, and it's known as Young's elastic modulus, we'll look at it, is known as the stiffness. So this is what's known as the stiffness for example, of the material or the implant. And the stiffer the implant, the higher, if you like, the resistive forces to the stress that's applied. The area under the curve is really known as the strength, and right at the very end, that's known as resilience, the darker part there. So if you apply this to your patient, you can see that in a 21-year-old, you're going to have a much higher slope, a greater slope, so greater stiffness with respect to their structural column, to their bone column, as opposed to your 80-year-old osteoporotic female, where it takes very little to exceed that point and have subsequent failure. So then we start getting into the implant dynamics itself. The section modulus, if you like, this is a term, and you know, it's jargon, I guess, but it conveys an important concept. It's a reflection of the strengths of the implant, and this is the point about this. So your strength of your implant, particularly for an object like a screw, is related to the diameter of that screw, and it's the inner diameter. So just remember that when you implant your pedicle screw in your patient, for every incremental size in that inner diameter of the screw, you are exponentially increasing the strength of that implant. So, and we'll come to this with respect to tips later on. It's a real consideration for you. I remember good old Dr. Radoskuyan had the old monitor. It was 6.5 Kazemi or nothing. So now I'd like to kind of flip it back on him and say maybe it should have been 7.5 Kazemi or nothing from back in the day. So of course, you know, that's only if it's appropriate, because as Rod used to say, size doesn't matter, it's the angulation. So there you go. Now this modulus we talked about, it reflects the stiffness to this force. As I said, the slope with stiffness. It's a ratio, and it's different for each vector. So with respect to the directionality of the force that's applied to the screw or to the bone, it's not this constant, but it depends on where that force is applied. And for various material, this stiffness, this elastic module, is different. So titanium, which is the most common implant that we use, has a huge elastic modulus or stiffness measured in gigapascals, compared to cancellous or cortical bone, which is cancellous bones typically about 0.5 all the way up to about 20 or 30 with cortical bone. But look at the other things. So PEEK is kind of in that range. Stainless steel, cobalt chrome, way off the chart. So if we want to kind of select an implant that most resembles bone, which is what we want in terms of avoiding failure, this is an important idea to kind of keep in our minds. And that's a table of kind of average figures as well as density. So what are some other characteristics of implants? They're ductile. So how able is the implant able to to withstand deformation before it completely fails? How brittle is it? So what's its elastic behavior right up until it fails? So ceramics are key to this, because they're able to be elastic, and then they fail. The strength, we talked about this, resistance to deformation. Fatigue failure, so if you keep stressing the implant again and again, what's the highest level of cyclical stress, if you like, before the implant fails? Notch sensitivity, so this is kind of particularly important with something like a rod, where we create a stress riser where we bend it in the rod, and what's the extent of the sensitivity of that bend there before it fails. And this is particularly important. We'll get to this. Ultimate tensile strength, maximum amount of stress that the implant can withstand before fractures. Toughness, energy per unit volume. Roughness, measurement of the surface finish of a material. This sounds like athletic kind of performance in the Rio Olympics or something. You know, I could be a commentator here. What's your ultimate tensile strength in the beach volleyball? So And Hooke's law, obviously, the stress is related to the strain produced. So, in other words, there is that proportionality, and the implant acts a little bit like a spring. We see that with a rod. There is some degree of, if you like, momentum or spring with respect to bending that implant. So, what about the bone? So, bone's interesting because, and the name doesn't matter, it's jargon, but basically it also acts differently with respect to strength depending on what's applied and which way the forces apply. So bone is weakest in shear, which again was that angular deformation, compared to tension or distraction compared to compression. And if you have a cut section of your cortical and cancellous aspect of a vertebrae, you'll see that the trabeculae are lined up such as to resist compression the most. And that makes sense because they're axial loading versus an angular injury or distraction kind of injury with the force applied at 90 degrees. So this is kind of a graph that shows you that. So it takes a significantly increased amount of force to lead to failure in compression as it does for shear. Bone's viscoelastic, so in other words, the stress-strain characteristic depends on the rate at which it's loaded. It changes with age and disease, we all know this. There's this concept known as Wolff's law, which says that it's also dynamic in the sense that it is able to adapt. It increases its density compared to load, and that's important because we all will tell our osteoporotic patients to do weight-bearing exercises because that will increase their density and lead hopefully to an improved clinical outcome. So we've talked about this stuff. Now, what about the ideal implant? What are we looking for? So we said originally that there were some goals for it, but specifically we want the implant to be inert, so it doesn't obviously react to compounds in the body like oxygen and oxidize. It's got to be non-toxic. It can't leach. And all our implants to some extent are toxic, even including titanium. There are studies done that looked at the titanium serum levels, and it leaches into the body, but hopefully not at a level that is clinically important. It's got to be strong. It's got to resist cyclical load and fatigue. It should have this low elastic modulus. So despite the amount of stress that's applied, the strain is little. It has to be corrosion proof, and that's related to its inertia or inertness. It's got to be able to resist wear over a period of time, and it's got to be inexpensive. So what do we use? So typically our implants are metals, and historically we started with stainless steel. We graduated to titanium alloys, and occasionally we're using cobalt chrome now. What others? There are some others that occasionally we use. Has anybody used anything other than metal for implants, particularly with rods? PEEK, exactly. Dynasis, yeah. So, and we'll tackle that in a moment. Have you, Dr. Sanser, have you used a PEEK?
Just last week, I did a case where the proton beam was going to be part of this future treatment, and they wanted to come up with a strategy to optimize the future treatments. And so one of the benefits of PEEK is that it can be penetrated by proton beams. So I skipped the level of the lesion as far as the pedicle screws were concerned, and instrumented above and below and put on PEEK rods, and that way they're not going to interfere.
Yeah.
So with proton beam therapy isn't that common, but I think it will become more common.
Yeah.
And especially at the University of Maryland, we have a proton beam center. So it may be something that I'll be doing more often.
Yeah, and it's interesting you say that. I mean, one of the major advantages of PEEK is that it's relatively radiolucent. You can code it to see where the implant is but it's good for artifact with respect to imaging. It's great for a segment or two, as you said.
That's used is carbon fiber.
Yeah.
You know, and you know, they have carbon fiber implants in Switzerland that also are very good for proton beam therapy. They even have the screws that are made out of the screw shafts that are made of carbon fiber, and it's just the tulip heads that are made out of titanium. They're not FDA approved in the United States, but we're thinking about trying to get those in, you know, and through compassionate use to have them permitted at our hospital.
Yeah. We'll tackle. We'll actually. I've got a slide on interbodies that carbon fiber and it's really interesting. The one problem with PEEK in particular as a rod is that you can't use it for deformity correction because it's not stiff enough. So it'll give way. But for a segment or two, then it's great. So as we said, ceramics and PEEK are the other non-metals. So what's the deal with stainless steel? It was the original implant. It's still a very, very good choice. It's typically made up of iron. It's ferrous with some other elements to it to improve its strength and reduce its corrosion. The advantages are that it's strong, it's ductile, it's biocompatible, it's super, super cheap because it's been around for so long and you can customize your implant pretty easily. The problem is that it's susceptible to stress corrosion because of its oxidization. And of course, it's hugely artifactual on imaging. So high strength, easily bent or contoured, but also susceptible to stress. Titanium alloy, this is what we typically all use. It's not just made up of titanium, but there's aluminum and vanadium and some other things in there. It's particularly resistant to corrosion, which is its advantage over steel. Again, excellent biocompatibility. It resists fatigue. It's got that low elastic module on the curve that we saw. For the most part, it's MRI compatible. You can do a little bit better by utilizing certain protocols on your MRI sequences to even minimize the artifact even better. The problem is that it's notch sensitive, and this is what we talked about before. So you will create a stress riser by bending the rod. And if you do that too much because you weren't happy with your correction, it's particularly subject to failure. You should get rid of it and start again. It is systemically toxic, but that comes from the vanadium part, and it's kind of expensive, especially compared with steel. Cobalt chrome. Okay. So this has particular uses, and I want you again to think of kind of conditions and situations where you would use this implant, given everything that we've talked about. So if you have a situation where you need stiffness in the rod, particularly with a long construct deformity, and you need a very, very strong and stiff longitudinal member, part of the lever arm, you got to think about cobalt chrome. It's definitely excellent with respect to biocompatibility. It resists corrosion again. It's super strong. But the problem also is that because of its high stiffness, it leads to stress shielding, and the rigidity may actually challenge the bone rather than the implant. So in an osteoporotic patient where the patient's host bone can't deform or modify itself to the rod, then you're going to have a bone screw interface problem. There are some others. Nitinol, you've all heard of that to some extent. It's particularly effective because it's super elastic, so the metal retains its shape. It's got a high shape memory. It's resistant to kinking. It's typically kind of used as a locking mechanism. And the problem is it's nickel allergy, I guess, given it's made up of nickel and titanium. PEEK rods we talked about. Again, we said it's a great option when we want to share the load. And again, its elastic module resembles bone much more than the metals. But the problem is that it's not useful for deformity when you need the stiffness to correct. And again, here was some of the kind of elastic numbers, if you like. So rod bending, we talked about this. So it'll lead to fatigue failure if you do it too much. So the point here is select a pre-bent rod. Select a pre-contoured rod if you can, because the metal was shaped like that when it was manufactured, and there will be less of a stress riser. And titanium is particularly notch sensitive compared to cobalt chrome. It's easier to bend, but it's particularly sensitive. So what about some other implants other than rods? So sublaminar wires were really effective for a long, long time, and they still are, for correcting the deformity of the apex of the curve, because you can pull the segmentally, you can pull the lamina and hence the rest of the vertebrae to your rod, and it improved the kyphosis by doing that. The problem is obviously it can cut by being cutting through the porous elements of the bone. It's a fiddle because you have to feed it under and feed it over, particularly in the craniocervical region. It can lead to neurological injury, imaging artifact. So they came up with alternatives, like this is a universal clamp where it's a nylon or braided kind of material, and it has a larger surface area and it shares the load. And you can use it, as we have, to supplement your fixation. So it's if you like, it adds to segmental fixation by adding more attachment points. Interbodies, the PEEK. So this is kind of our most popular, if you like, in terms of an implant. It's fantastic for load bearing because it can be shaped to whatever position you want. It's manipulated pretty easily into the disc space. You can drill it. It works well with allograft and osteoinductive materials such as BMP. The problem is it's plastic. It's polyether ether ketone. It will never integrate into bone. And for some reason, and for that reason, some surgeons do not prefer it, particularly in areas such as the cervical spine, where other good options are available. You can coat it with titanium, and that will improve its osseous integration. But overall, it's a workhorse. Titanium. So we talked about this. So much better for osseous integration. You can modify it to integrate with fixation. Problem is, because it fuses, it's difficult to remove, and typically you lose some vertebrae if you want to get it out. Carbon fiber, we mentioned before, very close elastic module to bone. Problem is it's hydrophobic, so by theory it'll push if you like, the interface away by not absorbing of water or fluid in that region. But the way around it is by coating it again. So it's becoming much more of an option. Okay, we talked about rods, implants. Let's talk about screws a little bit, and this is kind of key to a lot of what we do. So just some basic anatomy here. The screw is made up of not just a diameter, it's made up of a major and a minor diameter, or an outer and an inner diameter, which refers to the thread diameter and the core diameter. You have a thread depth, which is the distance between the tip of the thread down to the core. If you like, the importance of that is that the mirror image of that, if you like, is the bony surface area that's in contact with the screw, particularly when it's relevant for pullout. Pitch refers to the distance between the threads. So a cortical screw has typically a higher pitch or increased numbers of thread per surface per unit area in order to acquire or purchase more of the cortical bone, as opposed to cancellous bone where less thread is required. Screws can be conical. You can cannulate them, and you can pass them over a K-wire, or you can inject cement through them in order to achieve better fixation to bone. And they can be coated with hydroxyapatite, which improves their osseous integration. So what's important with a screw is really a couple of things. It's failure, really. And the pull-out strength of a screw is related to the material shear strength of the bone of the material that it's going into. So if you like, the shear strength of the vertebrae that we talked about is related to its density, and it's related to its ability to resist those threads from pulling out. And the shear area thread of the screw is important with respect to the amount of total surface area that the bone is exposed to the screw and hence must overcome in order for the screw to be pulled out. Okay? It's an equation basically, and they're multiplication of each other. This area thread is easily measured by the difference between the major and the minor diameter. So if you have an increase in the major and minor diameter, your implant has a huge thread difference, that's going to improve your pull-out strength or your resistance. It's related to the pitch as well, but it's divided by the length, if you like. So when we talk about this, what's important here? There's a few mechanisms of screw failures. One is the pull-out that we've mentioned. The other is that the screw may not pull out, but there may be such increased cyclical load on the screw from motion that it will fail. And it'll fail by fracturing, typically at the bone-screw interface or at the junction between the head of the screw and the core of the screw or the shaft. And in the past, in order to better manufacture these screws, there was a reduction in the diameter of the screw between the head and the rest of the length of the screw, and that's been corrected, as it was often a stress riser, and that's where a fractured screw would happen. And you also have this concept of the cantilever. We talked about this cantilever bend where there's a bending moment. So if you end up applying too much axial load to the cantilever, what'll happen is it'll fail, and the cantilever will, through shear, will change its direction. So when we talk about windshield wiping of the screws and pseudoarthrosis, that's what's happening. So you're applying greater load through the region that you're wanting to fuse. It gets transmitted to the implant, and as a result, that force overcomes the shear resistance, and you have a mismatch. And you have a cantilever bend effect. Typically, as I said, again, it's related to pseudoarthrosis, and it's a failure. So how are we going to improve this? And this is kind of, I guess, one of the key points that I want you to kind of take away from here. So select the largest diameter to reach the cortical surface of the pedicle. So I guess the take-home message is that you need to apply particular attention to your preoperative imaging and select your implant size, your screw diameter, with respect to the maximum purchase that you can get, particularly of that inner cortical diameter and the inner cortical surface of the pedicle. So if you have an option of putting in a 7.5 or an 8.5, do that, because you're going to significantly reduce the failure of the implant and its pullout. Cortical screws are a really interesting screw. I think they've become a lot more popular. Basically, the theory is that it purchases the cortical part of the bone for the reasons that we talked about. The screw itself is different. It's angled from medial to lateral, and typically it's placed from an inferior to superior position because that represents the cortical aspect of the pedicle. Greater pitch screws, technically a little bit more of a fiddle, particularly if you're relying on X-ray, but it's definitely a good option. It's a shorter screw typically as well. Here's another point. There is no additional benefit from extending the screw past about 50 to 60% of the vertebral body. So if you're way past the pedicle and you're at the 50% yard line, you're not going to gain anything by going right to the end. In fact, the problem obviously with parallax is that you on a lateral image you put in a screw that goes to the tip. In the thoracic spine you can exceed it, you can breach the cortex, and it's a risk to the important structures like the big red that you've got there. Triangulate your screws. you've got to increase the angle of the medialization of these screws, because again, that will improve the pull-out force. Tapping's it's become more optional as I've gone through my training. I started by all my teachers, mentors telling me that I needed to tap. And I think as we've become more expedient with our instrumentation, and we have more time pressures on us, I've noticed that we're tapping a lot less these days. The problem with tapping is that it reduces your bone surface, actually removes bone up to about 20% by doing that. And that's an issue. So the theory was that you would under tap by one size, 1 millimeter or so on. For cortical screws, you don't need to do that because, again, in principle, you're not going to remove that tough bone there. So you tap to size. I think the advantage to it is that firstly, it makes insertion of the implant much easier, but also it improves its pull-out strength as well, by a little bit, not by much. And of course, you can augment your screw with cement, and that may lead to a better option in certain conditions, such as osteoporosis. Okay, well, in conclusion, there's really kind of 3 goals that I want you to take away. One is that you've got to understand some basic biomechanics, and that includes these moments that we talked about. It'll let you understand the shear stresses and the forces applied. You have to match your instrumentation to both the condition you're treating, but also the host, if you like, and the condition of the spine. So an osteoporotic elderly spine is treated with a different implant potentially compared to somebody much younger. And alignment, as you've heard right throughout this weekend, and you'll hear, is the key to reducing instrumentation failure. Your outcome is best if you maximize everything: your patient, your instrument, and yourself. Okay, thank you.